后面我们一位讲者呢是来自澳洲的刘高瑞医生，他是有关也是静脉胶的一个探讨吧。So our next speaker is Gary Liu from Australia. He's a senior vascular ultrasound technologist and specialized in lower limb venous insufficiency hemodynamic analysis. Okay. Dr. Liu?
Hello, good afternoon. My name is
你好，
Gary Liu, and
主持
I
人可以
work
听
as
见吗？
a senior vascular sonographer at Nepean Hospital in Sydney. It's my great honor to give a presentation today at the third Global Venous Forum. And today I'm going to talk about some of the complications of glue treatment. So chronic venous insufficiency has traditionally been treated surgically by high ligation, saphenous vein stripping, and phlebectomy. And over the past 20 years, there's been a trend towards less invasive, office-based, and non-surgical procedures. And based on the technique, there are two types of endovenous procedures that can be performed for the correction of truncal reflux. And we're all familiar with the thermal technique. And treatments can include laser, radiofrequency, and microwave. And HIFU is a new non-invasive treatment, and closure of the vein is usually achieved by delivering high-intensity energy and ultrasound localization and guidance. And this technique has shown a high success rate and less complication, according to Professor Mark Whiteley in UK. And it also does not require venous access to the target vein. In comparison to thermal technique, some treatment methods manage to close the vein by chemical reaction. And for example, sclerotherapy and MOCA are used for treating truncal vein by destroying the endothelium. Cyanoacrylate glue treatment is a novel non-thermal method for treating varicose veins. And current evidence suggests a similar efficacy to other endovenous methods, but with a better safety and patient experience. Now, on this slide, we're going to compare some of the benefits and disadvantages of both thermal and non-thermal methods. And based on the new European consensus document, laser and radiofrequency have become the gold standard for treating saphenous reflux because of the high long-term success rate and less complication, short recovery time, and easy performance. However, there still have a number of disadvantages attributable to the nature of the technique and the use of tumescent anesthesia. If this treatment is performed under local, and patients may experience pain and uncomfortable stretching sensation from the needle and administration of tumescent anesthesia. And there's also a risk of skin burn and nerve injury associated with this method. And if the vein is too close to the skin or not encapsulated enough by tumescence. Because glue is non-thermal, it doesn't have all these complications, and wearing compression stocking after treatment is not a requirement. And another advantage of this method is we can actually assess if the vein is completely closed after the injection of glue, whereas this can be very difficult if laser or radiofrequency method was performed because of the tumescence in the leg. Here is a recent study performed by radiologists from Turkey, and the authors found a similar closure rate between radiofrequency and glue, as you can see. This is the systematic review of the efficacy of glue treatment as opposed to laser treatment. It's noted that most of these studies use Turkish glue, and 12-month closure rate are almost identical between glue and laser. In Australia, there are various glue agents registered and used for treating varicose veins, including VenaSeal, VenaBlock, and VeinOff. And VenaSeal was initially designed by a company called Cepheid and was acquired by Medtronic, and it is a catheter-based device registered as a medical device in 2012 in Australia. And VenaBlock was developed by a company called Invermed in Turkey and was granted with PGA registration in 2016 and also as a medical device in Australia. VenaBlock is designed for both catheter-directed administration and direct percutaneous injection. And VeinOff is also developed by the same company and tailored for percutaneous injection. and it received TGA registration in Australia in 2017. So out of the three types of glue products, Venasul has the highest viscosity and longest polymerization time, resulting in a slower action when it comes contact with blood or water. And this data was sourced from Medicaid Australia. And from the graph, we can see there hasn't been a significant change in the number of laser services performed. Radiofrequency ablation was introduced in Australia in 2012, and they have been steadily gaining ground on laser service. By 2020, radiofrequency has surpassed laser, and mainly due to its availability in many public hospitals, whereas laser procedures are primarily carried out in clinics. Furthermore, we began using glue from Medtronic in 2017, and over the past 5 years, the number of glue service provided has grown significantly, closing the gap with both laser and radiofrequency technique. So this is our room setup for glue treatment. So the vascular surgeons sit on the left side of the bed and the sonographer sitting on the right side of the bed. So we have two screens, and nurse also help us assist intravenous glue procedure. This is what's included in the glue pack. So we have the glue, 5 mils of glue adhesive, and we have a dispenser gun, a catheter, introducer, dilator. We have a 2-3 mil syringe, and one dispenser tips, and also a J-shaped guide wire. So I've got this short video to show you how glue procedure is performed in clinic. This is what we have in the glue pack. First, we gain access to the vein from the distal segment of the target vein using an ancient gauge needle, and the wire is inserted to the junction, making sure it's a clear pathway for the catheter. And the catheter is inserted into the target vein at a distance 5 centimeters below the subcutaneous junction, and then we start delivering the fluid into the target vein. But the sonographer will have to move from 5 centimeters in the junction to 3 centimeters below the junction. So we actually move 2 centimeters up, and then we start compression there to stop the glue traveling into the deep system via the saphenofemoral junction. So the first injection, we compress for 3 minutes. And after that, every 3 centimeters, we'll deliver the glue. And at 9 centimeter interval, the sonographer will compress the vein down to stop the fluid traveling up, and also it increases the contact between the vein wall and the glue. And the vascular surgeon usually have to stop at 5 centimeter proximal to the access point to prevent the glue extravasate from the target vein. Obviously, just like endovenous laser or radiofrequency treatment, this technique does have some complications. For example, hypersensitivity, phlebitis, granuloma, STP. EGIT stands for endovenous glue-induced thrombosis, or PE, injection site complication, and all the other complications which we can get from the laser treatment and sclerotherapy. This table is from a systematic study performed to evaluate the complications after glue treatment. And again, the majority of the study used Turkish glue. It's interesting to mention that DVT were not observed or reported. However, STP and phlebitis are very common, and the reported granuloma formation at the injection site ranged from 0% to 27%. So this is the normal ultrasound appearance after glue treatment. So the vein usually causes acoustic shadowing underneath the target vein, and the degree of shadowing is proportional to the amount of glue injected. This is just another slide to show the normal appearance after the vein was glued. We should use color Doppler to assess the treated vein to make sure there is no flow signal within this vein. Now, when we do a post-op DVT scan, we should measure we should assess the junction and making sure there's no anovenous glue-induced thrombosis. And so the measurement of the distance between the glue and the junction should be obtained for long-term monitoring of the glue extension. This is the example of type 4 hypersensitive. So patient developed erythema after glue treatment on day 3. This is example of granulomas due to extravasation of the glue. So you can actually see this lesion within the subcutaneous tissue, and it is outside of the target vein. And the granuloma often occurs at the access point. This is the same patient, and vascular surgeon removed the granuloma, and this is the ultrasound after the removal of granuloma. This is the patient we have done recently, and the patient developed anovenous glue-induced thrombosis immediately after the glue treatment. And the ultrasound, you can actually see this count extending from the saphenofemoral junction into the deep system and causing flow obstruction in the common femoral vein. This is another study, a glue-induced thrombosis at the saphenofemoral junction. Also, this is actually a type 4, so the DVT is completely occluded the popliteal vein. So to conclude my presentation today, this is the lessons we've learned from early experience of glue treatment. First of all, the JY and dilator should be advanced slowly and carefully under ultrasound guidance. And second point is the first compression should be performed at 2 centimeter proximal to the catheter or 3 centimeter distal to the saphenofemoral junction to stop the glue traveling into the deep system. And the subsequent compression should be performed proximal to the tip of the catheter. Last drop should always be 5 centimeter proximal to the access point, and retract the catheter before the pullout. For vascular surgeon and sonographer, we should confirm the vein closure and exclude anovenous glue-induced thrombosis at the end of the procedure. And the last point is always give patient informed consent. Let them know the possible complications of glue treatment so they are aware. So this is my presentation today. Thank you so much for your listening.
好，感谢Gary 的这个报告。那么大家有没有问题？
那我问一个问题啊，就是这个一个是这个胶水是不是因为都是做临床实验都是打在主干的，那么是不是可以把它用来直接在这个曲张血管内，或者说是像 Chiva 的治疗一样，直接去用它来去关闭一个 EP 点，这是一个问题。还有一个，你刚才也反复的强调，这个术后要再做彩超来看有没有某一段就是被 miss 掉了，里边还有血流信号。如果出现这种情况，就是比如说我们术后即刻的彩超发现，有部分的阶段里边还有血流信号，那怎么办？刘医生，我就是这2个问题，不知道能听到吗？
好，可以，主持人可以听见吗？
可以的。
好的，首先回答您第一个问题，是否可以治疗曲张表浅的曲张静脉？其实呢是可以，
但是呢，不建议使用胶，因为胶本身它不会被人体吸收。那如果我们打进去之后呢，那可能因为它太表起来，患者就会在这个腿部形成一个鼓包啊，这样永远都不会消失了。但是也有一些，看您使用的是什么样哪个公司的胶。那有些胶呢，它比较像美敦力的胶呢，它是通过这个注射枪来进行一个执行的，它是注射枪和导管在大眼静脉进行一个胶的闭合。那么有些品牌的胶像那个 Vanoff，它其实就是像和我看了朱岳峰教授的，他那个胶就是很稀的，它的粘稠度不高。那这种情况下，它是可以把它抽到这个针管里面之后呢，在超声引导下对反流的交通静脉进行一个胶的闭合。这个是我们医生有做过的。就是说，如果EP 点 escape point 是交通静脉的话，我们可以用这种方法对它进行一个治疗。那么第二个问题是，如果有阶段性的血流或者是反流，那么我们如何处理？那这种情况下，其实我们还是可以用硬化剂进行处理的。
好的，谢谢您。